Hi everybody, I'm Lauren Miller and I will be talking about small bowel obstruction. I'm going to start with my pants question. First pants question, a 60-year-old white male presents to the ED with fecal vomiting for the last 5 hours. He reports obstipation for 4 days as well as cramping, intermittent abdominal pain, and distension for 6 days. He denies fever, chills, weight loss, or changes in the mental status. Upright abdominal x-ray reveals air fluid levels in a step-ladder pattern in addition to dilated loops of bowel. He was diagnosed with having a mechanical small bowel obstruction and was hospitalized for observation and conservative treatment. Which of the following is not a significant risk factor for the development of small bowel obstruction? A. Post-surgical adhesions. B. A history of Crohn's disease. C. A history of foreign body ingestion. D. GERD on PPI treatment. And E. A history of abdominal wall hernia. Second pants question, a 36-year-old white female presents to the ED with abdominal distension and constipation for the last 5 days. She is nauseated but denies any episodes of vomiting. On physical exam, she is tender to palpation in all 4 quadrants. She is afebrile. She has a history of Crohn's disease and is 2 months status post a right hemicolectomy. Which of the following would you expect to see on her upright abdominal x-ray? A. Whirl sign. B. Air fluid levels in a stepladder pattern. C. A mass in the descending colon. D. Apple core lesion. Or E. Diffuse hazy gray appearance in the right upper quadrant. Moving on to the case study, this is a patient at a Kindred long-term care facility in Webster, Texas. Date of service 10/5/2015. He is a reliable source, and I was with Bay Area Gastroenterology, and we were consulted from a Kindred hospitalist. So the chief complaint, my stomach is really distended, HPI. Patient BD is an 81-year-old white male complaining of abdominal distension and pain, obstipation, and fecal vomiting. He has been hospitalized at this Kindred LTAC for the past 3 weeks being treated for pneumonia. His past medical history is significant for COPD, hypertension, coronary artery disease, iron deficiency, anemia, tubular adenoma with the resection, reflux esophagitis, and incisional hernia. He states that his abdomen has been increasingly distending over the past 6 days and has not had a bowel movement for 4 days. He reports that his abdominal pain is generalized to all 4 quadrants, colicky, and 9 out of 10 on the pain scale, and it's worsened. He states he started vomiting food boluses yesterday and has not been able to pass gas for 3 days. He denies fever, weight loss, diarrhea, oliguria, xerostomia, or localized abdominal pain. Past surgical history includes a sigmoid resection from that tubular adenoma complicated by an incisional hernia 5 years ago. No known drug allergies. No significant social history and no significant family history of colorectal cancer or inflammatory bowel disease. His GI medications consist of furosemide, megestrol acetate, ciprofloxacin, famotidine, lactobacillus, ondansetron, magnesium sulfate, clopidogrel, and aspirin. Vitals are stable. His BP 126/70, heart rate 76, respirations 14, temperature 99, O2 stats 100% on room air. General, he is on his physical exam, alert and oriented ×2, well-developed, well-nourished male with who is afebrile, who's on oxygen, and in mild distress from this pain. Neuromuscular and musculoskeletal are normal. Cardiac, regular rate and rhythm with distinct S1, S2, no murmurs, rubs, or gallops. Respiratory, clear to auscultations on the left, but the right, there are crackles in the right lower lobe. Equal chest wall expansion on oxygen. Abdomen distended in all 4 quadrants, firm, tender to palpation in all 4 quadrants, with a tinkling gaseous sounds in the epigastrum, left upper quadrant, and right upper quadrant. Lab work, white blood count 12, hemoglobin hematocrit 8.3, 28.2, platelets 396, electrolytes are normal, glucose 200, AST, ALT, albumin, total protein normal. Imaging, he has an upright abdominal x-ray that reveals air fluid levels in multiple dilated loops of bowel in the small intestine. Assessment-wise, so he is diagnosed with an unspecified intestinal obstruction of small bowel, in addition to iron deficiency anemia, unspecified, personal history of colon polyps with a sigmoid resection, an incisional hernia without obstruction or gangrene, severe COPD, hypertension, coronary artery disease, and reflux esophagitis. The plan is to order a CT to confirm a small bowel obstruction and to rule out cancer, masses, and mechanical causes. So consult general surgery if there is mechanical obstruction, including a mass or foreign object. Treat functional small bowel obstruction conservatively and educate the patients for signs of emergency such as shortness of breath, oliguria, fever. Differential diagnoses include volvulus, large bowel obstruction, ileus, and pseudo-obstruction. NPO with nasogastric tube sectioning. Continue IV fluids and monitor for signs of dehydration with the urine output. Recheck CMP and CBCs and monitor for anemia. begin opioid pain relievers and antiemetics, and then recheck an upright abdominal x-ray in 24 hours. Moving on to my disease is small bowel obstruction. So etiology, epidemiology, risk factors for that. Males usually equal females, average age is 64. Significant risk factors include adhesions being the most common risk factor for developing a small bowel obstruction. Second to that is hernias, in addition to volvulus, strictures from Crohn's disease, inflammatory bowel diseases, and prior abdominal or pelvic radiation. Also cholecystitis, intussusception, foreign body ingestion, and appendicitis, diverticulosis, or any kind of intra-abdominal abscess are all risk factors. Anatomy for small bowel is the duodenum, the jejunum, and the ileum, and location-wise, it's either a proximal or a distal obstruction, and a complete or a partial obstruction. So things that cause changes in the bowel wall include adhesions, inflammation, strictures, tumors, foreign objects. All of these change the normal anatomy of the small bowel and cause weakening of the bowel walls that could lead to dilation and edema. There are intrinsic lesions, extrinsic lesions, and intraluminal obstructions, all different types in the anatomy. Pathophys is either a mechanical obstruction or a functional obstruction. Mechanical is when there's an actual luminal obstruction in the lumen and it causes a decreased motility proximal, and on x-ray you would see air fluid levels and it's treated surgically. Functional obstruction is going to be like a post-operative ileus or pseudo-obstruction with decreased motility but may or may not have dilation and air fluid levels on an x-ray, and this is usually treated conservatively. So mechanical obstruction leads to the progressive dilation of the intestine proximal to the blockage and a collapse of the intestine distal to the blockage. When air is swallowed or when bacteria fermentation occurs, gases are released and collect in the bowel. The bowel wall may become dilated and edema and become edematous, and fluid will flow out, and this can lead to electrolyte abnormalities, nausea, vomiting, and eventually intramural vessels may become so dilated that the ischemia and necrosis can occur. So clinical signs and symptoms, it's usually a rapid onset of abdominal pain periumbilically that may be colicky or crampy. The patient will present with abdominal distension with a high-pitched tinkling sound that eventually becomes muffled towards the end. Constipation, obstipation, nausea, vomiting, focal tenderness would suggest ischemia, dehydration, and then fever. A fever would suggest an abscess, perforation, necrosis of some sort. So you can diagnose it, lab work, CBC, CMP, ABGs, serum lactate, blood cultures, all for signs of dehydration. Intestinal fatty acid binding protein can detect a bowel wall ischemia. Imaging studies. So you begin with an upright abdominal x-ray to confirm a diagnosis of a small bowel obstruction. It will show dilated loops of bowel with air fluid levels, with the fluid sinking to the bottom and air on top, and then this will be parallel when the patient is lying supine and perpendicular when the patient is upright. Proximal bowel dilation with distal bowel collapse and a gasless abdomen. On CT, use a CT to confirm a small bowel obstruction diagnosis. It's going to be the same findings as an abdominal x-ray with possible mesenteric edema, ascites, whorl sign or coffee bean sign can suggest a volvulus, which may also be present on top of the small bowel obstruction or cause a small bowel obstruction, and a target sign for intussusception, which may also be present with a small bowel obstruction. Complications include ischemia, necrosis, perforation, sepsis, and death. Prognosis would be good if it's a partial obstruction. If there's no dehydration, no malignancy, no perforation. Poor prognosis is if there's a complete small bowel obstruction where they need surgery. And then if you choose to do a non-operative management for malignancy, it's a bad prognosis. 50% of patients who present to the ER with small bowel obstruction will need to be admitted and treated. Non-operative management usually resolves within 2 to 5 days. Differential diagnosis includes paralytic ileus pseudo-obstruction from post-surgery ileus, large bowel obstruction in the large colon, or volvulus, which may eventually turn into a small bowel obstruction when the twisting of the intestines is on itself. So the management, medical and surgical, hospital admissions if acute, presentation, surgical exploration for complete obstruction, IV therapy, NPO, pain management, consult surgery, antibiotics for small bowel obstruction if there is necrosis or prophylaxis pre-surgery. Alternative would be a non-operative management for partial small bowel, early post-op SBO, chronic Crohn's disease, Functional pseudo small bowel is treated conservatively with bowel rest, IV, F, NPO, observed for no longer than 12 to 24 hours before you decide to go to surgery. IV therapy and the long tube decompression to avoid surgery in patients with small bowel obstruction. Moving up to answer the pant style question. So the first question, well, the answer was a GERD managed with PPI treatment is not a risk factor for developing a small bowel obstruction. GERD is a condition that mainly involves esophagus, stomach, and upper portion of the duodenum. This is incorrect because GERD it is not a risk factor for developing a small bowel. Second question, the answer is air fluid levels in a stepwise pattern is what you're going to see. And this is the most common finding on abdominal x-ray for small bowel obstruction. When the patient is supine, the air fluid levels will be parallel, and when they are upright, the air fluid levels will be perpendicular, and this is what you would see on an abdominal x-ray. Thank you.